A warm good evening to each one of you and good morning to our speakers. I welcome you all to Dr. V.K. Alexander Memorial National Seminar conducted by the Research and Postgraduate Department of Psychology, Union Christian College, Aluva. Today's seminar is based on the broad theme of multidimensional management of mental disorders. On this occasion, we have with us two special guests, Dr. Joy P. Kannarkat of batch 1967 to 70, who is going to talk to us on the topic Demystifying Psychotherapy, and Dr. Sonny Joseph of batch 1968 to 71, who is going to talk to us on the topic Psychiatric Drug Therapy. Let us begin today's session with a prayer song by Miss Rita from first year psychology.
ഹൃദയരാഗതന്ത്രിനീട്ടി സ്നേഹഗീതമേകിയും കർമ്മഭൂമി തളിരിടുന്ന വർണ്ണമേകിയും നമ്മിൽ വാഴും മാതിനാമം ഇന്നു വാഴ്ത്തിടാം. ഞങ്ങൾ പാടുമീ സ്വരങ്ങൾ കീർത്തനങ്ങളാകണേ, ചൂടുവയ്ക്കുമീ പദങ്ങൾ നിർത്തലോലമാകണേ. കുഞ്ഞു വീടിനുൾക്കളങ്ങൾ സ്വർഗമാകണേ. അമ്മ നൽകും ഉമ്മ പോലും അമൃതമാകണേ. പൂർണ്ണമീ ചരാചരങ്ങൾ ഗുരുവരങ്ങളാകണേ. ഹൃദയരാഗതന്ത്രിനീട്ടി സ്നേഹഗീതമേകിയും കർമ്മഭൂമി തളിരിടുന്ന വർണ്ണമേകിയും നമ്മിൽ വാഴുമാതിനാമം ഇന്നു വാഴ്ത്തിടാം.
Thank you, Rita. Now I invite Ms. Saina Susan Abraham, Head of the Department, for the welcome address.
Good evening and a very warm welcome to the Research and Postgraduate Department of Psychology, Union Christian College. It's my privilege to welcome all of you to the Dr. V.K. Alexander Memorial National Seminar. Dr. V.K. Alexander was the founding father of the Department of Psychology, Union Christian College. He was a psychologist of par excellence who had his Ph.D. from Princeton University. He came to settle down in Aluva in Union Christian College because he was inspired by the values of the founding fathers of the college and also the culture that the college represented, because he held the same kind of values. The small big man, small in stature but big in his work and his values and his love for people and for humanity around was the name or was the description that we hear from his students and the teachers and the community around us in Aluva. Dr. V.K. Alexander sir was probably the first practicing psychologist in the clinical field in psychology. He popularized psychology in Kerala through his writings in every week in the supplementary Sunday supplement of Malayalam Manorama newspaper. He also this attracted a lot of people with emotional and psychological problems to Union Christian College, and he treated them through psychotherapy, and his students were fortunate to be part of this treatment and to meet and train under him in a very practical way. Dr. V.K. Alexander sir also was the guide of Dr. J. Jagdambiga, who was probably one of the first women to be in the Kerala State Mental Health Services. She took her Ph.D. under him from the then Kerala University, the only university in Kerala at that time. So his influence was multidimensional. The students, he established the psychology, undergraduate program in psychology. It was the first psychology program in Kerala in 1960s. And students from that time onwards remember him as a great person, a person with love, not just a great teacher and a psychologist, but a great human being for his humility and love to all human beings around him. It is our honor, it was my honor and students like me to hear about him every year through Dr. V.K. Alexander Memorial Seminar and Alumni Reunion of the department. His students from 1960s onwards constituted this, initiated this Dr. V.K. Alexander Memorial Seminar every February so that all his students can come together in memory of Dr. V.K. Alexander. And we also had this tradition of inviting alumni of the department to be resource persons of this seminar. And following that tradition of more than 30 years, this year we have two eminent psychologists. One is a psychologist and a psychiatrist, and the other is a psychologist, both students of Dr. V.K. Alexander sir. And this year we have Dr. Sonny Joseph and Dr. Joy Kanaka. Both of them were Alexander sir's students, and during the late 1960s and early 70s. So it's our privilege to listen about Dr. V.K. Alexander sir and also to the rich experience the students had and the heights they have traveled inspired by Dr. V.K. Alexander. So let me welcome all of you formally to this seminar. It's my privilege to welcome our principal, Dr. Rachel Renard Philip, who will join us shortly. Our manager, former student and head of the Department of Psychology, Reverend Tombstone, both the resource persons of this webinar, joining us from USA with long distinguished career in the field of mental health in United States of America. The participants of this webinar are very diverse. Students and academicians, researchers, psychologists from across the country and abroad are joining us, alumni of the department and well-wishers of the department, students and faculty members of Union Christian College, also students and faculty members from other departments in Kerala and outside. It's my privilege to welcome my own students as well as the current faculty members of the Department of Psychology. A very warm welcome to the webinar. And both Dr. Sonny and Dr. Joy would like to have an interactive session. The topic is on multidimensional management of mental disorders. So the rich experience, starting with the training under Dr. V.K. Alexander sir to their long distinguished career in USA. This indeed would be a great inspiration to all of us. So please be ready for the interactive session. Make best use of this opportunity. And I wish all the participants and the resource persons a very fruitful time ahead. Thank you and welcome once again to the department and the webinar in memory of Dr. V.K. Alexander.
Thank you, ma'am. Now I invite Reverend Thomas John, manager of the college, to speak a few words.
Our distinguished resource persons, our alumni, and other members of the faculty, alumni of the department, and my student friends. I had the privilege of being a student of Dr. Alexander, and then working with him for a long time, with him in the department as a lecturer. And then towards the end of his life, we always had a good friendship, and in fact, he inspired me to work in the field of counseling. I say counseling because I am not a clinically trained practitioner, but help people, because he used to send students with problems to me. So I used to extend this help to them. And so we call Alexa. Alex, my uncle, who was the principal of the Union Christian College, T.B. Nainan, was a close friend of Alexa. And so they used to sit and talk about mental health and some of the cases he has treated and so on. I as a young boy, used to listen to him, to them talking about all these things. So in a way, I'm inspired by the model of Dr. Alexander. And so I am grateful to him in many respects. So we together used to demonstrate hypnosis. And once he said, Thomas, even if you lose this job, you have something else to rely on. So I used to hypnotize, and he used to illustrate many things related to hypnosis as a treatment method. But later on, I stopped my practice because I am not a qualified person. I used to help, and my help was always in the field of psychology, as a counselor. Now we have two eminent people, old students who have been working in the US in the field of mental health, and along with all of you, I am eager to listen to them. And this is the centenary year, and I just wanted to say how much we look forward to the help of our alumni, not only for material resources like finance and all that, we need it, but more than that, we have to establish international linkages with other universities, other educational institutions. That is one area where our friends in US can help us, and also they can share this media of StreamYard or Google placement, Google Meet, and so on. We have never made use of the potential of these media. Now we realize, because of the COVID, we cannot come together, but we can use this media to our advantage. We can, without any big financial background or help from anybody, we can just come together with experts from psychology or various disciplines across the world. So I am glad that they are with us. I thank them for their enthusiasm and initiative, and hope we have a very good time of listening to them and learning from them. And what they are talking is something very dear to my heart, particularly demystifying psychotherapy, because I felt that we try to mystify ourselves in the process and pretend to be somebody who can solve all the problems. It is high time that demystify psychotherapy. So I'm eager to listen to both of them. And so I wish this seminar all the best, and hope we all have a fruitful time together. Thank you.
Thank you, Father. We will now be moving to the speakers session. I would like to remind the audience that they may post their questions in the comments section for the speaker to respond. You may post your questions while the speaker is speaking and need not wait till the end of the session. You will also find a link to the feedback form in the comments section. Kindly fill in the form to get your e-certificates. To introduce our first speaker, I would like to invite Dr. Sina M. Mathai, coordinator of this seminar.
Most respected manager, Reverend Thomas John, head of the department, Ms. Saina Susan Abraham, respected resource persons for the day, Dr. Sonny Joseph and Dr. Joy Kanaka, dear alumni, teachers, and my dear children. So I'm here to introduce the first session resource person, Dr. Joy Kanaka, to this session. And right at the time of the inception of the seminar, we were very particular about bringing in two eminent resource persons for this seminar, and we have great pleasure in having Dr. Joy Kanaka and Dr. Sonny Joseph as our resource for this day. Dr. Joy did his graduation in psychology from UC College, Aluva during the period 67-70, and then he did his MS and PhD in psychology from Howard University, Washington, DC, followed by his internship in clinical psychology at Hillcrest Children's Hospital, National Medical Center, and pediatric psychology at University Maryland Hospital, Maryland. Then he joined as assistant professor at the Norfolk State University in 1975, and then became an associate in 77 and to full professor in 1991 until he got retired in 2012. And during his tenure as he was the director of PG program in clinical psychology, PsyD program, and have taught a variety of psychology courses at undergraduate and postgraduate levels. He has chaired several doctoral dissertations and many such committees, and currently he's doing private practice in clinical child psychology in Virginia. So you can just imagine the amount of exposure he has gathered from his wide range of responsibilities during his tenure as a professor and also as a private practitioner. Sir, we are very lucky to have you as a resource and proud to be part of the same department where you did your graduation. On behalf of all the faculty and students from the department, I invite you to handle the session on demystifying psychotherapy. Thank you.
Over to you, sir.
All right. Thank you, Dr. Mathai, Sina Mathai, for a kind introduction. And I am honored to be a speaker today for this Dr. V.K. Alexander Memorial Seminar Series. It is definitely an honor, and thank you for the invitation. As we reminisced Dr. V.K. Alexander, we heard about him, which is all true, and he's a very honorable man in my memory. To make it short, truly a humble scholar. And he was a soft-spoken teacher, but the consideration he has for his students were always there when I was talking to him, or I could say any student we approached, he treated us more like his son or daughter. Truly a humble scholar. Let me extend my greetings from Virginia to Reverend Thomas John, the current principal of UC College, Dr. Rachel Phillip, head of the department, Ms. Saina Abraham, and the event coordinators, Dr. Sina Mathai and Shema Kaur. Thank you all. I also want to extend the greetings from Dr. Thomas Matthew in Cleveland, Ohio, who is the president of UC College Alumni Association of North America. The abbreviation is a little long, UCCAANA. So I had a hard time remembering it. So I abbreviated it to say UCC Anna, just like showing a big Anna to a kid. All right. Then I am in Virginia Beach, Virginia. Virginia Beach is about 200 miles southeast of Washington, D.C. on the Atlantic coast. It is the largest populous city in Virginia, and there is a few cities all around it: Norfolk, Virginia Beach, Chesapeake, Hampton. All these areas together are known as Hampton Roads. And you may remember, or some people may know, Norfolk as an old city. It is a old city, more like Kochi. Actually, my hometown is Kochi, because it is a big shipbuilding, the biggest naval base in the world, with all the aircraft carriers and so on. And you may have heard about one of the longest bridges in the world, that is the Chesapeake Bay Bridge Tunnel. It's about 20 miles long, and one end of it is in Virginia Beach. It's a beautiful bridge. You may want to look at on on the internet, Chesapeake Bay Bridge Tunnel. All right. So you have some idea where I am. And when I came for the job interview in 1975, that's the first time I came to Norfolk, Virginia Beach. I kind of liked it because this place reminded me of Kochi, with the Bay Area, with a lot of rivers, a lot of bridges, shipbuilding, and naval base, and so on. I am originally from Kochi, near the shipbuilding yard. Actually, our house was acquired for building the shipyard, and the new MG Road went through the middle of our house. For me to attend the UC College, I had to catch 3 buses to get there and 3 buses to get back home. So I was more like a day scholar student, came and went. I was not able to participate in the campus activities, a lot of them. That is my situation with UC College. The lecturers we had at that time was, of course, Dr. Alexander, Mr. T. Simon, and Mr. Tharagan. So those 3 teachers were our initial mentors into the field of psychology. As soon as I graduated in 1970, I came to US. I had admission here, and then all my experience is here. So what I'm going to say, many things may be culturally not relevant to people in India, but I will be speaking mostly in generalities. so that addressing the basic human nature in a way. But the way we practice here may be different from how you practice in India. Actually, practicing a field in a particular location in US is kind of little different from practicing in another location in US itself. Anyway, so what I'm going to say is kind of what I have extracted from my experience and readings and teachings. So I want you to look at it as more of a personal production of it and enable you to think through. And my attempt last few years, especially in the last 10 years of my career and beyond, was to look at things and see things in a historical perspective. So many things that we do today, I will claim as we go along that they are not new. They are stated differently with new words, with new formulations, or I may call it more newer packaging. But we will see it as we go along. When we now let us get to the topic. As we get to the topic, I know from teaching a long time, after about 15, 20 minutes of any talk, it gets to a boring point. So I am no exception. So about 10 minutes into the talk, approximately, I will pause for a minute and maybe say a joke or a riddle. I have chosen 2 or 3 riddles. These are riddles of the week. When I see my patients, they are all children. I have a part with them in which we say some jokes or riddles as a way to relax and make the connection. So these are the jokes or riddles of this week, actually, when I get to that. So when we talk about psychotherapy, any word that has the word psyche or psycho, automatically people think there is some mystery to it. Something mysterious is happening in psychotherapy. Actually, psychotherapy is a ubiquitous phenomenon. It's everywhere. Sometimes we call it informal psychotherapy. That is what happens when in a trusted relationship with a friend or an uncle or an aunt or a pastor or a priest, where you get a good suggestion or a good idea that impact a person's commitment to change or modify and go on with life in a better way. When we think about psychotherapy in a formal way, as provided by a mental health professional, the only difference is that professional has a lot of theoretical knowledge, all the philosophies and theories that of human nature, and also some facts that psychological knowledge has gathered, and to apply them in a way that would benefit that person. Even the famous psychoanalyst Franz Alexander has stated long time ago that much of what happens in formal psychotherapy is the same thing as in the informal psychotherapy with ordinary people who give advice or suggestions or some counseling. Okay. When we get to to the technical definition of psychotherapy, it simply says treatment of mental disorders with psychological means or psychological methods. So that short definition is a little bit loaded because it says treatment of mental disorders. So we need to know what is mental disorders. Okay. So in order to know what is mental disorder, we need to know what is mental order. So how do we know? In a way, we are saying what is we consider normal. So that normality is the order. When it is away from normal, abnormal, that is when we say it is a mental disorder. But what is a disorder? So disorder is when it is and something away from order. So let us see what the order is. Order is defined by the society they live in, the age, the occupation, the different roles, and the time. And what is normal also changes over a period of time in any particular setting. So it is a little bit elusive idea to define what is normal. So what I have always thought of normality is in the way Sigmund Freud has talked about it. Of course, Sigmund Freud has a complicated theory about ego and defense mechanisms and so on. And so one day, when he was almost on his deathbed, somebody asked Sigmund Freud, "Hey, Sigmund, you have this complicated theory about personality and that psychosexual stuff. Who is really a mentally healthy person? Can you tell us briefly what is a mentally healthy person?" Freud said 2 4-letter words. He said love and work. Anybody who is able to love honestly and anybody who is able to work honestly are, in his definition, normal. When you look at both of them, love means a human relationship. It could be friends, it could be all kinds of situations between caring people, but also it means a loving relationship in which sexual desires are met. At the same time, they are contributing to the society with having children and bringing up good children for the society. So clearly it is one of his or the best of defense mechanisms, sublimation. Work also the same thing. When you find an occupation, it is never in a vacuum. It is with other people also, colleagues and so on. And also the work is contributing to the society in some way. At the same time, it gives the remuneration for your self-sustenance and luxuries, food and house and all those things. So it is also a sublimation. So basically what I'm saying is that when we are assessing somebody for how normal or abnormal they are, or whether they're mental disorder, we are looking at how are they functioning in their relationships, in personal relationship with the spouse or the family or in the occupation, how they are doing their job or they have a job or okay. So any debilitating aspects of these two areas is what we generally look at in defining whether it is relatively normal or not. If you ask me, are there mentally healthy people in the world? I have to say probably no in a perfect sense, but relatively speaking, maybe mentally healthy. Maybe not, maybe a little bit less. We all have idiosyncrasies. And that is why even though one of the old Chinese philosophers said, Confucius said, when we talked about marriage, before marriage, you keep your eyes wide open. After marriage, you keep your eyes half shut. So you don't see things that you don't really may not like. So there is a lot of adjustments you have to make. All right. So when coming back to psychotherapy, one more thing about it is we all know the purpose of it. We all know we want a positive outcome. We want to bring some change in the situation, in the person's behaviors or feelings in a way so they feel better and they do better as a person with other people and do a better job, better working situation with the colleagues as well as whatever the work they do. Okay. The outcome is pretty simple in that sense. Even though all the theories have described an ideal mental healthy person as a self-actualized person or a person who reaches the genital stage or authentic life and so on. So ultimate, that is an aspiration. That is something we look for, aim at. So an adaptive life to work and loving relationship is what we are looking at. So in addition to the, when we talk about psychotherapy, of course, the outcome is in the mind. And also we are looking at the process. How do we do it? What happens behind the closed door between the therapist and the client or the patient? So that is where the theories come in, different theories, and according to the theories, the techniques, how the therapists act on it to bring about. So each, no matter what theory a person uses or group of theories, each psychotherapy session between a patient and the therapist is unique because the personality of the therapist and the unique situation of the patient, they interact in a customized manner. So many a times when I am doing therapy with children, I know I do it a lot different than my colleagues do in the same office. So there is that person factor interfering or interacting in the situation. Okay, so we will look at the process in a couple of minutes as to what exactly we are trying to do to make it simple. Okay, so I think you may have reached a little bit of a boring point now. So I am going to say the first riddle today, the one I got this week from one of my students. I'm not students, one of my patients. He's an 8-year-old. I usually work with children anywhere up until about 13 years of age. I used to work with everybody, but I found it more fun to work with kids under 12 and 13. So sometimes I start working with them when they are little, like kindergarten age, and keep working as needed. Then sometimes they come back even when they start going to college and so on. Anyway, so this child came to me this week, and of course, these days we are only doing telehealth, so it is video sessions. And we always set the stage because I want to keep the sessions in a light mood, relaxed. So whatever I say to the kids will have an impact as we go along. So one of the things, as I said before, is to have a little joke or a riddle, maybe by every session or every other session, depending upon what I come up or what they come up. So this child came up today, earlier this week, and said, Dr. K, I have a riddle for you. Yes, good. So he said, Dr. K, do you know why do ants, A-N-T-S, ants don't get sick? Why do ants don't get sick? I started thinking, hey. So I gave up. Tell me. He said, Dr. K, they have antibodies. So he got me. So I laughed, burst into laughter, and he also laughed for a little bit. And it was a timely joke because we are talking about antibodies, this virus, COVID, and all this stuff. So this joke, this riddle he gave, and the laughter, I consider it as a therapeutic moment. A child, 8-year-old, 9-year-old child coming and telling something, and an old man like me bursting into laughter. How do you think he feels? He feels like he is somebody who can engage with an older person and make him laugh loud, and his self-esteem went a little bit one notch up. So even though it's a little bit, we always have to remember in therapy that it is drops of water that make a full bucket. So the changes don't happen in bulk. Sometimes only very slowly. Okay. Hope we got over that boring point. And let us get to the next segment, few minutes. Okay. We are, Dr. Sinamathai made it clear to me that keep it simple. So I'm going to try to say it in simple, common terms. When we do psychotherapy, we are actually dealing with 3 major domains of human experience. There may be other minor domains, but 3 major domains. What are these domains? It's basically A, B, and C. A for affect. Affect means emotions, basically anger, anxiety, or sadness. That is affect. Second is B, behaviors. What actually we do, our actions, we call it our behaviors, actions, responses, speeches, all those things. When we are kicking or say a bad word and all those things, they are all actions. So behaviors. So A is affect, B is behaviors, and C is cognitions. Cognitions means your beliefs, your ideas, your opinions, your reasonings, your philosophy, anything that you think as guiding principle. Even your religious beliefs, even our religious beliefs, or political beliefs, whatever the beliefs that you believe is cognitions. So these are the 3 major domains. So typically, psychotherapy involves manipulating or tackling one of these domains or maybe sometimes more than one, to impact that domain as well as correspondingly or reciprocally the other domains. For example, one of the more popular kind of therapies these days is cognitive behavior therapies. So you can see from the word itself, cognitions and also behaviors. So cognitions is the main focus. In other words, in the form of cognitive behavior therapy, we have several forms of cognitive therapies. One started by rational emotive therapy by Albert Ellis or Aaron Beck or Meichenbaum, stress inoculation theory, and or positive thinking by Seligman, and all those things. So by changing the way we think, we are going to change the anxiety or the depression or the anger. So the theory basically is that if we change the way we think, our beliefs, automatically it has an impact on our emotional experience of anxiety and so on. So supplement that with behavior changes also. So we have cognitive behavior therapy. So so remember, it's all about tackling or manipulating one domain to impact the other areas. Some time ago, putting all these things together, there came a form of therapeutic approach, but nothing new as such, but packaged a little differently. It was called multimodal behavior therapy, multimodal therapy by a famous guy called Arnold Lazarus. Basically, he came with a format as to what he called basic id. So you could B for behaviors, I for this, S for this, and make sure all the aspects of human experience. Basically, he said basic ID. So it is about seven aspects, and to focus each of those aspects of human experience to be changed in a person. All right. And he coined the phrase technical eclecticism. You know what eclecticism is. That is being broad in accepting all the different theories and whatever techniques come from the different theories. So his idea was technical eclecticism, meaning whatever technique works with whatever problem, you do it. Don't be bothered by or say, I will only use this approach. I am wedded to this theory or only that theory. But whatever technique works, and use that. And that was called the technical eclecticism. Okay. So, so that is basically the process of psychotherapy. And sometimes some therapies focus primarily on the affect, emotions. So those therapies are the ones that somehow bring about emotions, emotional discharge, catharsis. You have heard of catharsis, one of the words we learned early on. That is basically chimney cleaning, all the smoke or the emotions, let it out. Okay, maybe once the emotions are expressed in some way, the cognitions may get better and the behaviors may get better. And if you are focusing primarily on behaviors, we have behavior therapies of different kinds with systematic desensitization or relaxation trainings, positive reinforcement, punishment, and all those strategies from that approach as well. And hopefully when the behavior is changing, other things will change too. Okay. Okay, so that brings us to the next segment. So before we go to the next segment, Let me say the next riddle that boy came up with. This is a boy I was seeing for a few months, and he doesn't like school. He doesn't like to go to school. So anyway, he has started going, and he is now getting a little bit better, not too much. He came and said, Dr. K, I have a joke today. And he said, he didn't say he has a joke. He said, I have something to say. He said, school is fun. School is fun. Oh, I thought we are getting somewhere. I said, oh, man, you started liking school? He said, Dr. K, it's a joke. Okay, so so I laughed again. I laughed at his insight, how to trick me. So again, that was, with children, it is always connecting with them in what they bring and turning it around. So a little bit. So when that happens, they begin to value what you say, or maybe they will take it a little seriously. Anyway, okay. The next part, probably the last part, I think time is going, so I'll make it quick. Let us look at 2 or 3 historical figures doing what we were talking about, behavior change, or making their situation a little better. Okay. And these are figures, these days in the new books, they don't include them. I don't know how many of you have heard of this guy called Avicenna. Avicenna has the nickname of Prince of Physicians. He is from Arabia, maybe AD, circa around 1000. He's in Arabia, and Avicenna was, as I said, Prince of Physicians nickname, and he has written the book called The Canon of Medicine, long time ago. Okay. And in his book, I have not read his book or anything. I have read this case written somewhere. In the royal family there was a prince, and the prince had a very unusual kind of behaviors. He believed he was a cow, C-O-W, a cow. And he was walking on 4 legs. He was a late teenager. And as his, what we may call today as a delusion, as a cow, and he was walking, and he was even saying he wants to be butchered. He wants to be killed, butchered, and made his flesh into some stew, and want everybody to enjoy his flesh as stew. And that's what he was saying around. And he has not eaten for some time either. So he is refusing to eat too. All right. So that was the condition of a prince who was everything, actually. So the king tried to get the help of Avicenna. Of course, Avicenna at those times, if the doctor comes and take care of the matter, the doctor gets killed, So the doctor, Avicenna, studied the case and see what am I going to do in the palace. So he studied the case, and then he already gave the instructions to the palace people. Okay, I will come and get the cow ready for butchering, and keep a very good knife, the butcher knife, and all ready. We will come and treat and take care of the situation. So he went there and asked, where is the cow? Where is the cow? Where is the cow? So this guy, the prince, came in 4 legs, and Avicenna took the knife, the butcher knife, and just before he used the butcher knife, or as he was getting ready, he felt the cow's body here and there, palpitated here and there, and he said, this cow is very lean. There is no meat on this cow. Nobody could enjoy this cow's meat or stew. So fatten him up a little bit. Then I will come 2 or 3 weeks later and butcher. So we all can enjoy better. Okay, so even before Avicenna left, they brought him some food and he was eating it. Okay, Avicenna said he will come 2 weeks later and butcher you, and left. So this prince started eating, and 2 weeks later, he was doing fine. He was started to walk on 2 legs and acting more like a prince. What happened? Avicenna, I am assuming, properly diagnosed his condition as nutritional deficiency, where the delusions came about and all those things. I don't know why that particular delusion. Maybe there is something magical about being a cow, or he was fascinated by it. All right. So here is the situation. What is the therapeutic part there? What is the therapeutic moment? How did Avicenna came about it? All right. So he clearly joined the delusion. He pretended he was going to give in to what the patient wanted, shared the delusion, I am going to butcher you. So clearly joined the patient, built a rapport with that, all that pretense. Then he implemented the change in cognition, how to think. Delusion is a cognition in a way, a false belief is what delusion is. So he was able to alter that delusion to by changing something organic, that is by changing the nutritional habit or nutritional pattern. Okay, so that is basically a cognitive therapy if you look at it. So the point I am trying to make is what they name today as cognitive therapy today and flush it out as brand new is not that new. Especially when in America, when things happen, it is almost like they invented the technique. They forget about where it come, even though there is ancestry tree and all those things going on now. All right. Now let us look at another situation. We all have heard about Siddhartha Gautama, the Buddha. Of course, you all know he was a prince, and he himself became puzzled when he was like 29 or so. He was married and he even had a baby at the time. That's when it dawned on him that life is full of suffering, and why is some others made him put into a cognitive dissonance in a way about life. So he wanted to find out more about life. In a way, he was pursuing a way of change in understanding. So he wanted probably better cognitions for himself. And he got it, and later on he became Buddha, the enlightened one, as you know. And he brought us meditation, and we always see the picture of him under that tree. and sitting and meditating and concentration. Of course, concentration is a very big thing. That is, we call it these days, we call it mindfulness, focused on one thing. Okay. All right. It didn't start with mindfulness as they call it today, but the point I wanted to make is a little different about Buddha. And one day, this is a story I have learned when I was in 5th or 6th grade or so. Some of you may have learned that too. When Buddha was sitting under the tree and meditating with full concentration, a lady came to him and lying down on her knees and crying, "Oh, my son died. I want him back. My son died. I want him back." And this lady was crying, and the Buddha was fully in meditation. And after a while, she got so loud, the Buddha kind of woke up. And Buddha looked at the lady and asked, "Lady, why are you crying?" So she said, "My son died. I want him back. I cannot live without him. I cannot live without him." And she was keep on crying. So what did Buddha say? "Okay, I will bring the boy back. I will bring the boy back." Oh. Suddenly the lady started hearing and listening. Then, "Whatever you say, I will do. I want the boy back." "Okay, I'll bring the boy back." So Buddha said, "You have to do one thing. You have to go and bring me a tablespoon or some amount of salt. Bring me some amount of salt, the table salt that we eat, the salt from a house. And when any house, you can go and ask for the salt. And when you get that salt, ask them one question. Have anybody died here? Okay, if anybody has died there, that salt is not any good. Then you go to the next house. The lady said, "Okay, I'll bring right now. I'll be right back." She went after house after house to get that salt. But any house she asked, "Has anybody died there?" Yes. In some houses it was children. In some houses it was middle-aged people. In some houses it was old people. After a while, many hours, what happened? She came to that conclusion, that cognition, that death happens everywhere, at any time or any age. So what Buddha did was, again, gave her hope that he will bring the boy back so that she will do what he asked him to do. And while doing it, it dawned on her the new cognition that death is an ubiquitous phenomenon. That is, it happens in every family. So she slowly got over that grieving process. So what did Buddha do? Gave her a prescription to do something. A prescription. That's what doctors do these days, prescription. Okay. There is a group of therapies, especially in family therapy literature, whether it is Salvador Minuchin or Jay Haley or Chloe Madenas, all those, they call it strategic therapy, strategic family therapy or strategic therapy. So you got the idea. They have a strategy to implement, and doing that strategy, a new cognition emerges and behaviors also change. So that's the idea. behind there. Then one more thing, and then I will go to the very last thing I would like to say before Sonny takes over. Okay. Now, we all have, most of us are religious people, whatever the religion is, that gives us a set of ideas and principles to guide our behaviors. Okay. Union Christian College, a Christian college. I'm a Christian, I'm a Catholic, I'm a practicing Catholic, kind of devout in that belief system. So what the religion provides us is a set of cognitions. Okay. And also a set of prescriptions. So the first list that comes to my mind is that tablet with 10 commandments. You all know the 10 commandments that in the Old Testament we have. Moses got it. And in a way, that is our behavior chart. Behavior chart to guide our behaviors. Okay. And that behavior chart comes with a mighty, powerful reinforcement. That is heaven. If you follow those behavior chart pretty well all your life, you are guaranteed to have that positive reinforcement, the eternal reinforcement of heaven. And if you don't follow that, what happens? You have the eternal punishment of hell. So, a clear example of behavior therapy in play with larger, later reward of eternal life. But it is contingent on what we do now. Okay, so this contingency of behaviors and reinforcements is the basis of operant conditioning as we know it today. And I rarely have heard anybody connecting the operant conditioning to 10 Commandments or other religious beliefs connecting to heaven. Okay. But of course, Skinner followed the idea of Thorndike and others, law of effect, and formalized it, standardized it with nice terms, quite appropriate. And this behavior therapy, of course, you must know, or we all know, it had been practiced. My great-great-great-great-grandmother probably. I'll give you a simple example. Whether it is in India or whether it is in America, many children suck their thumb, and it has become a habit, and they don't give it up, and somehow they like it. All right, and you can have different theoretical explanations, but the great grandmas did in India or Kerala was the technique called chennayam. Chennayam is a liquid or something that is so bittersome, and if you lick it, if you rub it against the fingers, and if the child sucks the thumb, it is going to be so bitter that he wouldn't want to do it, he or she. So clearly it was punishment technique, aversive conditioning, that we call it today. Okay, fine. So the point I'm making is, when we look back, these principles, a lot of them that we are doing have been applied and practiced successfully long time ago. So that is what I am trying to say about demystifying. So this behavior change that we can bring about. So, of course, there are more dramatic forms, but we always, as scientists, we want to do or follow the law of parsimony, meaning the simplest explanation possible for a phenomenon. Okay, that's the idea. Okay, now, as I am going to conclude, let me say the third riddle for the week I got. This child, again a boy, I mostly see boys, there are some girls, but this boy doesn't like math. Math is his difficult subject, and he says he hates math. And all right, so sometimes last week when I talked to him, he showed me some fractions, and he is having trouble with fractions. So I told him, I help him a little bit to understand sometimes, but to join him, I do a little of that, learning things. So this week he came and said, Dr. K, I have a math problem for you. Oh, now he might be turned on to math. So he said, okay. So he said, Dr. K, do you know why number is afraid of 7? Number 6 is afraid of 7. I have never heard of that math problem. So he said, I said, I don't know, my dear. So he said, 7, 8, 9, meaning 7, 8, ATE, 7, 8, 9. So 6 is close to 7. So 6 is afraid 7 might eat 6. So again, as usual, I laughed and enjoyed the trick. So, all right. I hope you enjoyed my riddles more than the talk. Now, finally, let me conclude this with setting the stage for Dr. Sonny to take over. That is, I talked about the 3 domains, the behaviors, the emotions, and the cognitions. When a typical patient comes, we assess, sometimes we have to be on the lookout, what are the organic or biological basis for this condition, what we know of. Sometimes those are, old term is endogenous reasons or external reasons, exogenous situational things, today what we call stressors. And we know there is both most of the time, but the ones that are primarily with the external reasons, stressors or hardships or difficulties or conflicts between people, that's what we are trying to help. Of course, the one more serious ones with neurological basis, such as bipolar disorder or schizophrenia and so on, which we know the hereditary base. And many times a common phrase in America is chemical imbalance. That's why people get depressed or anxious and so on. So in a way, that chemical imbalance phrase is a catchy word for common people to know, to demystify mental illness or psychological problems. Oh, it has to be something physical. Okay, so we play along with that. It is physical, and it is helpful to treat them with medicines. And I think for the most of the situations, the medicines play a big role because they set the stage for a person to receive the psychotherapy process, to participate, at least calm them down enough in their behaviors or in their emotions. So some reasoning or some order can come in place so that lifestyle changes can be made by changing their thinking or behaviors. So it is almost like the medications are preparing the ground, a fertile ground for a seed to grow. So the point I'm making is the research studies clearly show, whether it is anxiety disorders or mood disorders, when both psychotherapy component is there as well as the medication component is all there. So when the treatment is more multidimensional in terms of preparing the ground and allowing the seed of cognitions or behaviors to take place, that is, the studies show when those two things are done together, there is better outcome. So with that said, I will quote one thing that is a long time ago when I started postgraduate study. There was a famous book at that time. It was called The Myth of Mental Illness by Thomas Sass. And the myth of mental illness he translated into saying the problems in living. So that are what we are faced with most of the time. Of course, there are all problems in living, whatever the etiology, whatever the reason is, the cause is. I usually present this way to the kids or to the parents. When they come with some difficulties, I always tell them, children are in transition, are developmentally going, evolving. So as we are in transitioning, we get to some road bumps. Some place we get a little stuck. So we need a little plan to help them overcome, whether it is through medicine or whether it is through psychotherapy or counseling. So a number of times, maybe both. And as in America now, one of the things that we see most often is the diagnosis of ADHD. And, I don't want to go into a lot of details about it, but if it is a true ADHD situation, attention deficit hyperactivity disorder, the medication treatment along with a behavioristic approach helps the most. So right now I'll stop and let Dr. Sonny Joseph talk about the medication aspect of treatment, and then we will take any questions and all questions to elaborate something I said or something new. All right. Thank you very much.
Thank you so much, sir. It is time for the second session. I call upon Ms. Shema Elizabeth Kohur, also a coordinator of this program, to introduce our next speaker.
Thank you, Meghna. Before I start with my job of introducing Sonny sir, I would like to tell you, Dr. K, I truly enjoyed your session, your riddles, and I like the way you really demystified psychotherapy with such simplicity. Let me go to my task at hand. It gives me great pleasure to introduce Dr. Sonny Joseph, an esteemed alumnus of the Psychology Department of Union Christian College, Aluva. He studied in Union Christian College from 1967 to 71. Sonny sir is a respected senior friend of ours, and Sonny sir has been a huge inspiration to all of us through his webinar interactions that we have had with him and all other times we have interacted. with him. I have not been fortunate to personally interact with Sir, but through the activities and the communication of the department between Sir and the department, I have heard a lot about you, Sir. Usually, we find among mental health professionals, a person may excel in being a psychologist or a psychiatrist. Here we have a combination in Dr. Sonny Joseph, our respected speaker, a multifaceted expert who trained himself in the best way possible as a psychologist. He has a post-graduation and a Ph.D. degree in clinical psychology. Also, he has another bachelor's and master's degree in medicine and psychiatry. Additionally, Dr. Sonny Joseph holds a postgraduate degree in health administration. Sir has a really vast knowledge base, and it's very interesting to listen to him because his insights come from both psychology as well as psychiatry. But that's not it. Sonny Sir is someone who enjoys sports, games, music. His love for football has prompted him to be engaged in refereeing and managing a unique format of football called Gandhi soccer. In his own words, his study and stay in UCC has been his richest college experience among all colleges he attended. Some of the foreign universities he attended were University of Ottawa, University of Juarez, Mexico, Harvard University, and MIT. Sonny Sir has worked as clinical director of mental health clinic in Barrow, Alaska, and as clinical psychologist in mental health clinic in Ohio, and presently practices as a solo practitioner. He's been practicing for over 30 years as psychiatrist in Orlando, Florida. I'm sure that Sir's session in Dr. V.K. Alexander Memorial International webinar will be really enlightening to all audience, near and far. Over to you, dear Sonny Sir. Thank you.
Hello, good evening, everybody, and thank you, Dr. Sina, and also Dr. Thomas Matthew, who introduced me to the webinar series. Since I already made a presentation that touched on my UC college experiences and highlights of the other places that I studied, if you don't mind, I could skip that because I'm sure most of the audiences are the same as were present in the previous session. So during if you want me to go briefly into the background, I will, but I assume that that's already known. So I would like to go into the practical aspects of psychopharmacology treatment, especially that as it pertains to my experiences with consulting with many people in Kerala in terms of their particular difficulties. My observation has been over the many years when I visit Kerala is that the prevalence of mental illnesses is the same in Kerala. Especially what I have found is that there is a preponderance of mild paranoid disorders, excessive personalization. They present with symptoms of mild depression, anxiety, insomnia, but there are people that are very prone to such misunderstandings, overreactions, overreading into things that cause considerable, especially in the interpersonal arena. And they are very, very difficult to treat, and they cause major family problems. in most of those cases, their insight is so poor that they are unwilling to accept that they have a difficulty that is their own, not because somebody else's problems. They want to attribute that to other people's difficulties. But those who are willing to be treated with medications, there are many excellent medicines nowadays. If you recall the history of medication, the initial major medication was chlorpromazine, that is thorazine. I think in India it's called Largactil, that was introduced in the 1950s, which considerably improved the symptoms of major disorder like schizophrenia. And at very low dosages, we even use that nowadays for severe anxieties, although there are better medication options available now. The other common condition that I have seen in India is mild bipolar tendencies with, or what's also known as cyclothymia, which is a milder form of mood cycles, mood swings, but mostly consisting of hypomanic tendencies where people overdo things. They become overconfident, and they end up resorting to excessive alcoholism in Kerala. Not so much drug abuse, perhaps it's becoming more popular now. And the psychopharmacology is a very vast topic. So I'm just going to give you some tips that I have found very useful for most people to benefit from various medications. Obviously, there are major medicines that are used for treating major mental disorders. There are antidepressants. There are different classes of antidepressants. And there are antipsychotics. There is the first generation antipsychotic, and the chlorpromazine is an example of a traditional antipsychotic. And there are newer generation antipsychotics, such as risperidone, olanzapine, aripiprazole, that are commonly used. They work mostly as adjunctive medicines to go along with antidepressant medicines, because, as I implied before, many of the mild depressive symptoms are initial presentations for underlying what Kraepelin described as dementia precox and Bloiler described as simple schizophrenia. Now, schizophrenia is a scary word, but it's unbelievable how many people have very mild form of schizophrenia that affect their motivation in life, especially what we see are people or students who are exemplary in their high school years, but slowly become less able to continue their studies at the same level. So the parents have such high hopes due to their gifted performance during high school years, but the performance dwindles gradually. It's a very insidious, slow process that even many doctors will take many years to make a proper diagnosis and provide the correct treatment. By then, a lot of damage has already been done. They've failed, they withdraw from programs, but they don't achieve the promise that they held previously. And there is a new, well, it's not a new trend. It is a form of applying basic biology with psychology, and that involves use of low doses of medications, but in combinations. So it's very hard to find pure diagnosis in the field of psychology. So it's not just depression. There is usually some anxiety, excessive worrying, being overly sensitive, being overreactive, over personalizing, some insomnia, some mood cycles. So the idea is to use low doses of different medicines from different classes, as well as using behavioral technology, especially health-oriented technology, such as exercise and good diet and good habits. But what I have observed lately in Kerala and in most other countries is that most people have given up on spending time outside, either walking or light jogging or sports and games. I've observed that many colleges now have converted their playgrounds, football fields, hockey fields, badminton fields, into buildings probably because of lack of space. But that makes it difficult for a young student in college to express themselves and in fun activities besides their studies. It affects their growth as a full person, and instead they focus more on solitary activities like watching TV, going on Facebook and so on. Fortunately, in my particular case, and again, I don't want to use me as an example, but I always encourage my patients when I prescribe medicines to pursue therapy on the side. Although I don't do therapy myself, I encourage patients to see a psychologist for gaining psychosocial insights once the acute symptoms are controlled. So if somebody is having trouble sleeping, or if somebody is overly irritable, easily frustrated, overly defensive, that needs to be addressed to the point that they are able to gain the insights that they gain from therapy. Otherwise, for instance, if a person who is very irritable pursues therapy without the use of a little bit of medicine, they become so defensive that it's harder for the psychologist to educate the patient as to their own difficulties, so that awareness, that introspective awareness, helps the patients to control their inappropriate, excessive emotions without having to rely on a very high dose of medicine. So the advantage of therapy is that we can get by with lower dosages, and if they involve in therapy. And another behavioral intervention that I always recommend to most people is to go on solitary walks, not walks with the groups, which fine as a social activity, that's fine. But the advantage of solitary walking or solitary light jogging is it not only gives you better physical health, but it also gives you time to do introspection, which is almost being your own psychologist, your own therapist. The thoughts percolate in your mind, and it gives you insights that a psychologist might give, or it reinforces what was discussed in therapy by the psychologist. And so this and a healthy diet. But in order for people to involve in solitary or even a group sports activities, they have to give up on TV, they have to give up on Facebook, Twitter, whatever they use these days. I'm not a member of Facebook. I'm not into Twitter. I don't go into any of those things. I would rather just go out and take a soccer ball and just kick around and run around. It has helped me personally with my personal frustrations, stresses, and obstacles in life. And as much as I have achieved, I have also had many obstacles. And fortunately, I've been able to improve on those on my own, approaching this from a biopsychosocial standpoint. Now there is another field that you can call it what I term cosmetic psychopharmacology, because if you carefully delineate the thinking, the reactions of I would say 99% of people, you can find some things that you can improve using medications. So I believe in medicines. I studied physiology, I studied medicine, and I apply that in my own life. Not only in mild, for instance, I am a shy person. But there are medicines that can improve my shyness if I have to perform in a situation. I could find light combinations of medicines that I can improve myself. I wouldn't call it a major mental illness. It's just a tendency that people have. So there are tendencies that all of us have that can be theoretically improved with medications, at least whether it is well-founded or not. I have the confidence to find the medicines, if they are willing to improve the overall psychological functioning of most people, if they would let me do that. And I'm not talking about serious medicines, for instance, for shyness or stage fright. There is a just to give you an example, there is a combination of a beta blocker which is used for high blood pressure, but at very low dosages. The generic name is propranolol, just 10 milligram. That's the lowest dosage available. And using that medicine with a combination of perhaps gabapentin or very low dose of diazepam or Valium, which is a benzodiazepine. It's addictive, but at extremely low dosages for occasional use. That I would call it a cosmetic psychopharmacology, but it improves the quality of life of people. It improves performance. And the same is possible in physical active health. For instance, those who have type 2 diabetic tendencies or pre-diabetes, or those who have, for instance, if their A1C is, say, 5.6, there are medicines that do not cause major side effects that can bring down the A1C to 5.1, which translates to an average blood sugar of 101 milligram per deciliter, which is above the highest range that is recommended. So you have to realize, from a clinical standpoint, anyone over 5.7, 5.8 and higher is considered a pre-diabetes. But why wait for that? So these are just some examples. Like I said, this is a very vast field. So I don't know where I should focus on. So if you have questions, I'll be happy to go over the details. One of the questions that I could not answer during my last presentation was, there was one psychologist that asked about the combination of bupropion, which is a dopaminergic and noradrenergic antidepressant, along with aripiprazole, which is a a second-generation antipsychotic medication. Yes, that's a nice combination. It doesn't work in everyone, but that combination is typically or usually used, especially those who have apathetic depression, meaning lack of energy, lack of motivation, loss of interest in activities that they used to enjoy. Bupropion alone or in combination with aripiprazole, whereas depressions that are characterized more by oversensitivity, being easily prone to becoming tearful, excessive worrying, or being overly irritable or easily frustrated profile, they respond a little better with the serotonergic antidepressants like fluoxetine, sertraline, paroxetine, escitalopram. I'm just giving you generic names so you can understand. The brand names are different in India and the brand names are different in the US, but the chemical names are the same. So this is just a little overall tips that I have, and if the audience has any other questions, I'll be happy to focus. And I'm sure there are questions that people have for Dr. Joy Kanaka. So you tell me. Dr. Sina?
ഇത് സെഷൻ കഴിഞ്ഞു. Thank you, sir. Now it's time for the question answer session. I also invite Dr. Joy sir also into the question answer session. Okay, sir. So the first question we have received is from Miss Saina ma'am. How often do you explore psychodynamics behind behavior, especially childhood trauma? Is this necessary or useful?
Okay. When we talk about trauma, these days, the word trauma is kind of overused. Because some time ago, in children, every child who was admitted to acute care was being diagnosed with bipolar disorder. And later these days, the American Psychiatric Association changed the diagnosis. No child can be given bipolar disorder diagnosis until they are 18. And they came with a new diagnosis, what they call disruptive mood dysregulation disorder or so. Okay, but trauma is important. Usually most of the time, the trauma here is happening in the form of child abuse or sexual abuse of children. Okay, so those situations are traumatic, and we have them. I do not go into psychodynamic explanations of that as such, but really within some details for 1 or 2 sessions or 2 or 3 sessions, because especially the younger the child are, very well that I don't remember anything that happened before I am 5 or 6 years old. So God has given us the brain to kind of not have that kind of memory from early on. Some of them are probably because it is by design. I don't know. But repeating the trauma again and again especially childhood trauma, I do not recommend. But it need to be processed in the therapy situation for a period of 2 weeks or 3 weeks, then allow it for them to get over that.
Thank you, sir. The next question is from Miss Malini. Sir, how effective are techniques like dialectical behavior therapy in managing PDs? Would like to hear from you based on your experience.
Dialectical behavior therapy, I do not know much about it. So, and I only see with the work with children. So I have not really kept up with the literature on dialectic behavior therapy. So I have to admit my ignorance on that topic as such, as a technique for personality disorders. So somehow over last few decades or 2 decades, 3 decades, I have seen only children. So I'm not up on that topic as such. Sonny, want to say something? As you see adults with the personality disorder.
No, I'm not familiar with, I'm not up to date with the psychotherapeutic techniques. So I'm sorry, I can't elaborate on that.
That's okay, sir. Thank you. The next question is from Lakshmi Devi. Sir, will high parental expectancy and strict rules imposed by parents to achieve that leads to personality disorders?
Yeah, I don't know about personality disorders as such, but high parental expectancy and strict rules are generally not good, because children need to play and discover. So, of course, achievement motivation is important, school performance is important, but not to take the time from play and spontaneous play with other children. So I always encourage in America, children as such don't get together like informal basis and have enough play time. So here is more organized in terms of gymnastic classes or soccer leagues or basketball, football, and only in rare communities that we see children in the neighborhood come together, and they are, basically the front of the house is most of the time streets, so they cannot play in the streets, but in backyards and so on. So playtime is very much an important part of learning. So but the achievement need to be expressed. More important these days in terms of school as high expectancy, it is more needed is supervision, because children these days are, even from schools here, children even get free Chromebook, computer with internet that expands their life into horizons that we can't even think of. So it is now a common thing that parents complain that children are going to different sites when they are not supposed to. Some of them are, adult situations also. So children are exposed to a lot of things. So parental supervision is very much important now than ever before. It is a little bit of a contradiction from some time ago when I first started talk about parental supervision. I was kind of ridiculed a little bit by some of my colleagues, saying that that's kind of supervision, knowing to know what is going on in the child's room, under the bed and so on. they made fun of me because the child has to have privacy and so on. So in my opinion, we need to know what the child is doing, and it is I had the in my house I had the open door policy, basically to walk in, knock and walk in. Of course, they have the privacy in their bathroom and so on, but generally speaking, parents need to know what is going on and follow up with the home rules, the homework, and so on. But the approach that I hear sometimes, that as soon as the child is born in Kerala or India in a fairly well-to-do family, they are trying to prepare the child for IIT. Okay, so in my opinion, of course, moderate force and supervision, but not to the extreme. But more important, the point I want to make is that more important, of course, certain level of achievement is necessary, but more important in success in life is social relations. So that interpersonal relationships and the sportsmanship that they learn in a sports setting, not that they will become a soccer star or basketball star, but the sportsmanship, following the rules and taking orders from the coaches and the referees with that frustration tolerance, and maintaining a congenial relationship between other colleagues is that determine more of success.
If I could,
go ahead.
If I could add something that's in that same line, combining psychology and some play. If I could take a minute for this, I have, due to my interest in many games and psychology itself, I have published an article that you might want to look up. It's a non-monetized article. It's a free online article. The psychosocial. Let me bring it. Psychosocial analysis of soccer problems and solutions. So, if anybody who is interested in football and connecting the psychosocial dynamics to the play itself, if you want any of your family members very much into football, it's a very detailed article using lots of psychology concepts. You can just Google it. My name, Sonny Joseph Soccer, and it should come out. It's a free. You can print it out. As well as I also have a 5-minute YouTube video, which is also non-monetized. So these are purely educational publications. If you just click on YouTube search bar, Sonny Joseph Soccer, there's only one video. It'll come up. And so it'll be a fun experience on a lighter spirit.
I made sure bringing up my children, they played sports and I played sports. Sonny and I used to get together and play some tennis. And when I was visiting Sonny, we were eager to play soccer, and Sonny was impressed with my soccer skill. So what the point I'm making is that that social skills that they acquire in that other context, and the personal relationships and the social connections, not the skill of relating to people, that is more important than success. Of course, you have to get in the door, but with the academics and so on. But after that, it is that interpersonal skills that they build from childhood on. So limiting that could lead to some maladaptive personality characteristics, and I won't go to the extent that it can get into personality disorders, but that also depends on the genes.
Thank you, sir. The next question is from Seena ma'am. The The question is, what are the common disorders you see in children in USA?
Okay. The primary one that I see is because of family breakups. Children dealing with situations where the parents break up, or single parent families where there was no marriage to begin with. Then academic problems, and many of them get diagnosed with ADHD. Many of them are not really ADHD, but they're a reflection of the confusing home situation, the disorganized home situation. And many times the young parents are not with the skills, are not with the interest in child rearing. So because their own personal needs are still there, so many of my patients, some of them live in with children live with grandparents, and sometimes grandparents who bring them to me, and so on. So so getting the children to somehow to organize their life around the confusing family situation they are faced with is what the typical situations are. But there are other things, some fancy situations that are going on, that is diagnosing children with autism spectrum disorder. Because for some educational benefits or programs, they need that diagnosis. So they are coming to get that diagnosis and somehow written down to get that special services. But if you look at all the things, this autism, as you know, is a broad spectrum. We are all autistic in some ways. Sonny is a little shy. He said he's a little autistic. I am a little autistic. So that does not matter. But it is we overcome those things. But this is the primary situation that I see is the children are becoming more aggressive and they are exposed to more things. And on top of it, the disorganization they see, and we expect the children to do things that the adults don't do. For example, many a times I get the situation where the children call out, "Mom, you don't do that. Why you ask me to do it?" So a typical situation is the siblings are not getting along. They are fighting, or siblings should fight anyway. I am never happy to be alive, or my brother is happy to be alive because of the way we fought a long time ago. The children are fighting and they are calling each other names, and parents ask them, "Why don't you behave this way, that way?" The boy asked, a month ago, the boy was brave enough to ask, "Hey, mom and dad, you fight. You're fighting all the time. And so why you say don't fight?" So they are seeing the different things. So that kind of, the parents get called on these things. So the family change, the consistency, and that I would say what I am seeing is more like that sense of safety and security is not there as much. That is the main kind of concern that I see in the children being anxious or a little bit with worries. They get sucked into the difficulties that parents have. And one of the, probably the ADHD is the one most commonly treated condition now.
Thank you, sir. We have another question from Sanjay. Can we apply psychotherapy effectively for changing diet patterns? For example, people with diabetes and children with obesity.
Yes, any behavior management situations should help. But as I talked about the cognition and the behaviors. People need to be educated, and their belief systems have to be modified somewhat. So as they begin to believe that, health is something that we can control ourselves, it is within our reach by our behaviors, like what we eat, exercise, like Sonny said. So basically we call it lifestyle changes. So clearly diet patterns can be changed, but there has to be some motivation for it and education part for it, as to that health is something that you control. That is one thing in America, as you know, or probably everywhere. We say in America, we say health care, or the health care is a basic right. Everybody has to have health care, and the government has to provide it. This is a big topic. But people are not taking personal responsibility for their health. They eat all kinds of things, loaded with French fries and Subways and this and that, and they get, overweight. Okay, and over top of that, smoke and all those things, and they are not taking care of their health. If they don't take care of, why, when we do things that we know clearly what is harmful to you, we are not following a healthful pattern, and for all the mistakes you do, when you want somebody else to take care of you. So basically what I'm saying is that a good lifestyle program can be implemented through the counseling process. And also it is important to know, in some cases, the food becomes the self-soothing pattern of behavior. Then you need to look into what other issues are going on. And maybe Sonny can say in some cases some medicines can help too, because some psychological conditions are going on there. And you were asking specifically about children. Of course, these days, the convenience factor of food, but it is a little bit changing. I see more parents are thinking about children's diet with a better judgment.
Thank you, sir. The next question is from Elizabeth. The question is, pharmacotherapy has an upper hand in India over psychotherapy. Is it the same in US?
It is more acceptable that way, because as I said, people are beginning to believe that there is chemical imbalance, and that need to be the common phrase, and they say that need to be corrected, and which, like Sonny said, pharmacology is what the people generally prefer, because it is short. In their opinion, it is like taking a pill, and that will help. And also that kind of belief is promoted. If you look at the TV ads that come on this from the drug companies on these different kinds of medicines, like memory loss, this and that, sleep disorders, insomnia, and all those things are getting the people to think that is what they need to do. Of course, that is the shortcut method. But like Sonny said, and as I said, the solitary walking or light jogging or exercise is an important factor, along with diet. And the key word is lifestyle changes. True. The more and more media people have, celebrities have come out and talk about their struggle with their personal life. So that has helped the help people to seek psychotherapeutic help as well. So I had patients both ways, where they say, I need only the medicine, or they say, I don't need the medicine, I need only this. So
No, another point that I want to add to what Dr. Joy said, that in the United States, the healthcare delivery system tends to favor a simple, easier approach of using medications because it's cheaper, whereas a session of psychotherapy, for instance, for an hour, usually at least about an hour each session, can cost $150, $200, whereas to see a family doctor or a psychiatrist for a medication check, it's probably cost like $50, and the cost of the medication, which is another $10. And the insurance companies are usually reluctant to approve psychotherapy sessions, or they restrict the sessions. So the healthcare economics tend to favor easier approach of medication management. So just because, although that's the reality of the healthcare economics in the United States, but the other point that I want to make is that although there are medicines, the psychiatric medicines that can improve people's tendencies and performances, like I said, if somebody who's an somewhat on the introverted side, or someone who has some, or children who have attentional difficulties, like staying focused on a task, getting easily distracted, difficulty initiating tasks, difficulty completing homework, being overly forgetful, or hyperactivity such as restlessness or fidgeting. Although this can be improved, there is no reason to medicate all those tendencies and performances unless they seriously affect a person's academic functioning, or social functioning, or personal quality of life. So the point I was making with the cosmetic psychopharmacology is that I could improve, like I said, almost 95% of people if they give me a chance. It doesn't mean I should do that, or the people should accept that, because there are many tendencies and performances, although they can be improved, don't need to be improved. They are able to live with it. That's what we call personality tendencies. But obviously, for major illnesses or illnesses that affect our physiological functions, so if somebody is depressed or anxious to the point that they can't sleep, or they can't eat, or they overeat, or they overuse alcohol, for instance, that need to be treated. Otherwise, it's going to do the person in health-wise seriously, not only physical health-wise, but mental health-wise, and in terms of personal family harmony.
Thank you, sir. We have another question from Manju. The question is, what are the expectations of the recovery for an adult OCD patient with repeating his own words or sentences, thinking that the other person might not have understood, taking too much time in all acts, etc.? Sir, we would also like to personally know what kind of pharmacological management may be provided for this.
Joy, you want to go first?
Generally speaking, for the OCD patients like that, the prognosis is really good. The behavioral techniques somehow can be customized. What the particular behavior technique that I have in mind is what they call exposure and response prevention. And along with that, with the OCD patients, expertise of Sonny to use some antidepressant medications may be also indicated. So, Sonny.
Yes, from a medication standpoint, there are excellent medicines that are available, but one of the differentials that one has to keep in mind that when patients present with OCD symptoms, intrusive, repetitive, undesirable thoughts that affect their concentration and daily functioning, or rituals and repetitive behaviors that can also can seriously affect their other important activities, is a thought disorder, a form of simple schizophrenia. So there are many overlaps among these symptoms. So OCD can be an illness by itself, or it can be a symptom of a more serious underlying condition. And the medicines that we use, the most effective medicine is a tricyclic antidepressant called clomipramine. Here it is anafranil. However, it has slightly more side effects, like anticholinergic side effects, like dry mouth, sedation, increase in the heart rate. But again, side effects don't mean most people will get it. Some people do. So that's an important point to keep in mind. When people are prescribed a medicine, they go on Google and look up the side effects, and there are hundreds of side effects for every medicine. But the fact is that most people don't get them. So one has to try the medicine to know if they can tolerate the medication. But in any case, the clomipramine is the most effective medicine, but the most popular one is another SSRI, is a newer medicine called fluoxamine, which is in the SSRI family. That's slightly better tolerated. Or any of the SSRI medicines can be used, for instance, fluoxetine. But for through OCD, if there is no underlying psychotic tendencies, people tend to need higher dosages for some reason. So the dosages such as escitalopram that we can help with 10 milligram for a person with mild depression or mild anxiety, the person with OCD might need 20 or 30 milligram of escitalopram, for instance. So similarly, the dosages need to be higher. And additionally, we use combinations along with the basic SSRI medication, along with the atypical antipsychotics such as low dose of olanzapine, low dose of risperidone, low dose of aripiprazole, and in some cases they give very good results.
Thank you, sir. A small notice for the participants. A link to the feedback form has been put in the comments section. Kindly fill the form to get your e-certificates. The next question is from Shema ma'am. The question is, many college students experience anxiety and related issues. How do you know if and when medication can help?
I think the decision regarding medication is when the symptoms seriously affect a person's functioning. If the symptoms do not have a significant impact on their academic functioning, social functioning, sleep, then there is no reason to medicate. A better approach would be psychosocial approaches such as psychotherapy or involvement in social athletic activities to have a therapeutic effect. Like I said, even either group sports activities or solitary walking or jogging have psychotherapeutic benefits. So it's a determination that a person has to make whether or not the extent of the anxiety and related symptoms like insomnia or negative thinking or tension that can affect their daily functioning or affects their, for instance, their blood pressure or their appetite. So if these symptoms are affecting their physiological functions, which anxiety, which appetite would be one, or insomnia would be another, then and if initial interventions like therapy and stress relief and relaxation training do not work, then one has to rely on medications. Also, one has to make sure that the anxiety is not a symptom of a major underlying disorder, in which case that needs to be treated. Like Broiler said, there are, for instance, just talking about primary symptoms and secondary symptoms of, for instance, schizophrenia. The primary symptoms would be disorders of affect, autism or autistic thinking, association disorders or serious cognitive deficits, and ambivalence. And anxiety is part of that. So you have to make sure that there are no serious underlying disorders. And in that case, that needs to be treated usually with medications if there is a more serious underlying condition.
Thank you, sir. Since we are running out of time of the question answer session, we will take one last question from Saina ma'am. The question is, how could we manage procrastination among adolescents, especially when they are not showing interest or aptitude in any field, academics, sports, arts, etc.?
Well, if it is procrastination is one of the symptoms of adult or adolescent ADHD. So if that is a part of that symptom that systemically affects all activities, academics, but we don't worry about sports. But if it affects academics, that's serious because they can get turned off to school if they have difficulty maintaining their academic performance and grades. So you don't want an adolescent to get so turned off to school that it's just too late to give them a proper intervention. But I've heard that cognitive behavioral therapy that Dr. Joy might elaborate on might help with ADHD, but I have no expertise in that. My specialty is treating ADHD with stimulants such as methylphenidate or low-dose amphetamine salts, which I think are difficult to get in India. And I've had occasions where I've taken medicine when I visit India to give to either friends or family members whose children or relatives have ADHD. I don't know if these stimulant medicines are available in India now, but it's widely available here. But maybe Dr. Joy can elaborate on that.
Yeah. As you know, adolescence is a very difficult time. That is where a lot of dramatic changes take place. As you know, even the onset of schizophrenia in a way is linked with unusual experiences that happen during adolescence. So we have to look at to see whether there is anything else emerging in such a child. Sometimes it can be simply the fact that these children are maybe growing up in abundance, basically no motivation. Everything is provided for them. So I had a patient a few years ago. The father was a very rich man with this fish dealing with the fisheries and so on. And the father was offering him a present like a $250,000 car, Maserati for him, if he just bring up the grade to sea level, So we have to look at that situation, what is going on in that child, and also whether it started to happen rather suddenly. The child who was doing really well the last few years in the education, and then suddenly they lost interest. So we have to look at to see in that particular child where there is an emergence of something else happening. As it happens, as Sonny said, ADHD may be a factor which was now diagnosed early, but ADHD as such is not something that suddenly starts in adolescence. It is there from the very beginning, unless that ADHD, the concentration and irritability is a secondary symptom for something else, family issues or something else going on. So generally, I would say procrastination is symptomatic of something else.
Thank you, sir. There are some questions which have not been asked due to lack of time. We would forward these questions to the speaker and respond accordingly. The time given for question answer session is over. Thank you everyone for your active participation in this informative and useful seminar. We have reached the end of this seminar. I call upon Ms. Fatima Siad, Association Secretary, for the vote of thanks.
Good evening, Mananta. It's my privilege to have been asked to propose vote of thanks on this occasion. I, on behalf of Department of Psychology, UC College, extend a very heartfelt gratitude to everyone attended the webinar. First of all, I would like to thank Dr. Rachel Rina Philip, Principal, UC College. Thank you, ma'am. Then I thank Reverend Father Thomas Jonathan, Manager, UC College, for his address. Thank you, sir. Then I thank Ms. Saina Susan Abraham, Head of the Department. Thank you for your welcome address. Then I would like to thank a very heartfelt gratitude to our resource persons, Dr. Joy P. Kannarkat and Dr. Sonny Joseph. Thank you so much for your very interesting and thought-provoking address. Then I extend thanks to Dr. Sina M. Mathai and Shema Elizabeth Kovu, coordinators of today's webinar. Then I would like to thank Akhilesh Thomas Sonny for all his technical support and Meghna Menon for comparing. Thank you. Then I thank all faculty members and all participants of today's webinar, especially all students. Thank you all. Thank you so much.